Hi, my name is Nicole Noe. I chose to do my presentation on gastroesophageal reflux disease, otherwise known as GERD. I chose this disorder because it's something I have a personal connection to. I was diagnosed with it 22 years ago and have been dealing with the symptoms ever since. Despite having it, though, I wasn't familiar with the pathophysiology or pathogenesis of it, so this was a good opportunity for me to learn more. And I can tell you that understanding GERD is essential, and this presentation will cover causes and symptoms, as well as diagnosis, treatment, complications, and management. The etiology of GERD is caused by regurgitation or reflux of stomach acid and gastric contents. The acid flows upward through the lower esophageal sphincter, otherwise known as the LES, and into the esophagus. Currently, there is no known specific cause to explain the development of GERD. It is caused by multiple different mechanisms, which can include things like structural factors, intrinsic factors, and external influences, which we will talk about in a few minutes. But regardless of causative mechanisms, GERD is a chronic disorder, and chronic meaning it persists for an extended period of time, sometimes for life, and it requires ongoing medical management and sometimes even surgery. It is the most commonly diagnosed digestive disorder in the US, and up to 20% of the population experiences significant symptoms. Anatomical factors can play a part in etiology, and that can range from esophageal dysmotility, impairment of the sphincter tone, delayed gastric emptying. This can be seen in other disorders such as gastroparesis. Hiatal hernias can cause problems. Bacterial presence like H. pylori, or even abdominal pressure related to pregnancy or obesity can all play a part in causative factors. Lifestyle factors can also play a part, but there is increased evidence that there is a genetic component. For example, problems with the FOX1 gene, which affects smooth muscle in the stomach, could lead to structural issues that wind up triggering GERD. Surprisingly, heritability could be as high as 43%. The pathophysiology of GERD is fairly basic, even though it can cause a lot of problems. The primary barrier that prevents gastric acid from flowing backward into the esophagus is a ring of muscle, and this is located at the junction of the esophagus and the stomach. This is called the lower esophageal sphincter, or LES, which is what I will be continuing to refer to it as. A normal LES is highly toned and strong, and it closes after eating. This prevents regurgitation of gastric contents. In GERD, however, the LES is compromised and unusually weak, so it doesn't close properly, and it allows the contents of the stomach to flow backward. This can sometimes even go as far as the pharynx and nasal passages, and this phenomenon is called laryngopharyngeal reflux, or LPR. I have had personal experience with this, and I can tell you it is absolutely terrible. Consistent high levels of acid and pepsin, which is a highly acidic digestive enzyme in the esophagus, can lead to inflammation and even erosion of the esophageal lining. Normally, peristalsis in the esophagus helps clear acid, but in GERD, peristalsis may be severely reduced, so this allows acid to stay in the esophagus and further exacerbates inflammation. So GERD is often paired with a weakened diaphragm. In normal physiology, the diaphragm helps prevent reflux by contributing to pressure around the LES, and this helps it stay closed. Some factors can cause weakening in the diaphragm, which in turn weakens the LES pressure and allows it to stay open, causing acid reflux. And we can see here, this is the hiatus where the esophagus goes through the diaphragm, and this is the LES here where the stomach contents can flow backwards if the LES is weakened. And you can see it in this diagram as well. GERD can come with a great deal of signs and symptoms. Not everyone will have every symptom, although some people may, and they can range in severity from mild to unbearable. Some can be an uncomfortable annoyance, while others can be truly frightening in their severity, and I can attest to that personally. In the early stages of the disease, the symptoms can also go through periods of remission and exacerbation depending on various factors like diet, medications, and stresses in one's life. Unfortunately, without in-depth testing, GERD can be difficult to diagnose because many of the symptoms are not easily measurable and therefore not clinical signs until imaging studies are done. But I can tell you from experience, the symptoms can range from being uncomfortable to agonizing. I was actually diagnosed with this when I was 13 years old, which is a very young age, apparently. And what led me to seek a diagnosis was I was having some really severe problems with dysphagia. I could not swallow food very easily. It would get stuck, and I always felt like there was a lump in my throat. At one point, I actually had a bout with the laryngopharyngeal reflux I mentioned earlier, and acid was quite literally bubbling out of my nose and mouth, which felt like someone was just running a sheet of fire up through my esophagus and into my face. It was absolutely terrible. So those are pretty severe, but other signs and symptoms can include, and heartburn is the major one. Heartburn is a burning or icy sensation in the chest and sometimes the throat, and this is very common. A feeling of regurgitation of food or sour liquid into the throat, upper abdominal or chest pain. The chest pain can be different from what people think of as heartburn, and it can sometimes even be mistaken for a heart attack. This is usually due to esophageal spasms, which can be quite intense. Dysphagia, trouble swallowing, like I mentioned before, and a sensation of a constant lump in the throat, nausea and vomiting, excessive eructation or belching, shortness of breath, bloating, sore throat, and laryngitis. Some people can have dental problems, which is usually a reduction or erosion of tooth enamel from the acid that's always present. A dry cough or urge to clear the throat often, and new or worsening asthma symptoms can also be a sign. So a diagnosis of GERD starts with a physical examination where the patient describes their medical history and symptoms. If the symptoms are mild, the doctor will probably recommend over-the-counter medications and some lifestyle changes and then monitor their symptoms from there. If the symptoms are severe, though, there are multiple tests that allow internal examination, both visually and measurement of acid levels and esophageal pressure. So the first test that's usually done, and one of the most common ones, is called a barium esophagram. And this happens through the patient swallowing a barium solution, which coats the esophagus and gastrointestinal tract. An x-ray is taken, and the barium lights up the internal organs, which helps the doctor look for any abnormalities. Now, this test does not actually show the presence of reflux or acid, but it does evaluate the coordination of esophageal function, and it can show any injuries to the tissue. So in the left image here, we can see what's called advanced reflux esophagitis, which is inflammation. And you can see this through the irregular and serrated outline of the esophagus. This is probably due to the inflammation and maybe some ulceration as well. The right image here shows a stricture right here, which is a narrowing of the esophagus, and this could be caused by chronic reflux or esophagitis. Another test that is done is esophageal manometry, and this test does not specifically diagnose GERD, but it is instead used to rule out other conditions that could mimic GERD. And what happens during this test is a pressure-sensitive catheter is inserted via a nasogastric tube into the esophagus. And the catheter measures the strength and the coordination of esophageal contractions as the patient takes sips of water. So it's kind of measuring the peristalsis there to see if it is too strong or too weak or normal. It also tests the strength and relaxation function of that lower esophageal sphincter. Another test that is often done is called a 24-hour pH impedance test, and this test can actually measure the reflux itself. It does this by monitoring the pH levels in the esophagus for 24 hours, and it measures the amount of both acidic and non-acidic reflux. It happens through a flexible catheter with an acid-sensitive tip being inserted through the nose and into the esophagus. Acid levels are sent to an attached monitor for the doctor to review. The patient is advised not to take any acid-reducing medications during this testing so that it can get the most accurate reading, and they're encouraged to go about their lives eating and drinking what they normally would. This allows for the most accurate results. There is also a wireless version of this test, which isn't done quite as often, I don't think. A chip in this test is placed in the esophagus and measures acid levels for up to 48 hours. And the gold standard test for evaluating reflux-induced injury to the esophagus is called an upper endoscopy or esophagogastroduodenoscopy. This diagnoses various GERD or small intestine complications, and it evaluates the potential for those complications, which can range from ulcers to hiatal hernias to bleeding, and the list goes on, which we'll talk about in a few minutes. During an upper endoscopy, the patient is placed under moderate to deep sedation. Usually it's deep sedation, and they're given a hypnotic such as propofol. They can breathe on their own, so they don't need a breathing tube, but they feel and remember nothing. An endoscope with a camera is inserted through the mouth and passed down the esophagus and into the stomach. This allows visual access to the esophagus, stomach, and part of the small intestine. The doctor watches a monitor that's attached to the endoscope to see the camera feed. And surgical tools can also be passed through the endoscope for biopsy collection or polyp removal if necessary. I have personally had 3 of these tests. I had the barium esophagram, the manometry test, and I've had multiple upper endoscopies because in chronic GERD, they are often recommended every 3 to 5 years to continue to monitor what's going on inside. So treatment. There are 4 approaches to GERD treatment, and they depend on the severity of symptoms and whether there is any damage to the esophagus. A doctor will likely recommend the least invasive treatment first and work up to more invasive, which will depend on things like symptoms and test results. The first approach consists of lifestyle changes, and this is often recommended for those who have mild symptoms and no physical complications, so no erosion of the esophagus, no hernias, no ulcers, things like that. These lifestyle changes can include losing weight if necessary, avoiding certain foods and drinks, which we'll talk about in a few minutes, quitting smoking, and more. The second approach is medication treatment, and this is the one that I'm currently on. There are 2 categories of reflux medications, ones that decrease the acid levels in the stomach and ones that increase the motility of the upper gastrointestinal tract. Antacids like Tums or Mylanta, they neutralize acid and can be used over the counter for infrequent and non-severe reflux, but they will not heal inflammation, and they can cause side effects with overuse, which can just exacerbate the problem. Histamine blockers or H2 blockers are mostly available over the counter, although some can be given by prescription, and they work by reducing stomach acid. These include medications like Pepcid and Tagamet. H2 blockers work by blocking the histamine receptors in the stomach lining. Histamine stimulates acid production. So they can work up to 12 hours and have healed esophageal erosions in about half of patients. I take an H2 blocker or Pepcid twice a day, but I also take the next version of medication, which is called a proton pump inhibitor, and this can be both over the counter or prescription, depending on the strength needed. Mine is a prescription, and are the strongest of the acid medications. Over the counter includes Prilosec, Nexium, and Prevacid, and prescription includes Protonix, which is what I'm on, and something called Acifex. PPIs work by suppressing acid production, and they do this more effectively than H2 blockers. They work by inhibiting an enzyme that produces stomach acid and blocks the major pathways for acid production. These medications may heal erosive esophagitis in some patients, but they should be monitored by a doctor because they do have the potential for side effects, and unfortunately long-term use has been linked to osteoporosis. There are surgical treatments available for GERD as well, and these are often done in patients who have had it for a long time, patients who their symptoms really aren't managed well with medication, or they are having some severe internal issues like ulcers or erosion of the esophagus. And just as an aside, you have to be approved for these treatments depending on your symptoms, and I actually was just approved, so I'm trying to decide which one of these I'm going to do. But one of them is called the LINX Reflux Management System, and this is one of the newest devices for GERD treatment. It's this one here on the left. And it's considered to be one of the safest and most effective surgical procedures. The link system uses a small ring here of flexible magnetic beads enclosed in surgical titanium. It's placed around the esophagus at the LES, just above the stomach, and it works through the attraction of the magnets between the beads, which acts to keep the LES closed. The surgery is done laparoscopically and under general anesthesia, but it's usually outpatient, and the patient can resume a solid diet immediately after waking up. The TIF, or transoral incisionless fundoplication procedure, is the one that my doctor is actually recommending for me. And it's a minimally invasive procedure that's performed through the mouth without incisions. And with the help of a video device called an esophix that is guided through the esophagus to the LES, the doctor can create sutures and tissue folds around the LES with tissue from the esophagus and stomach. And this ultimately tightens and repairs the LES. You can see how that is done right here. The surgery is performed under general anesthesia, and it does require an overnight stay. Normal activities can resume in a couple of days, and research has shown that patients usually no longer need to take medication for GERD after this procedure. One of the most commonly performed surgeries for GERD is done laparoscopically, and this is called a laparoscopic fundoplication. 4 small incisions are made in the abdomen for a camera and surgical tools, and the surgeon takes a portion of the fundus, which is the upper part of the stomach right here, and they wrap it around the bottom of the esophagus to form a valve. And the fundus can either be wrapped completely or partially around the LES, but this ultimately strengthens the LES and prevents backflow of acid. So you can see here how this is done. This can be either inpatient or outpatient, depending on the person, but it requires a liquid diet for a couple of weeks post-surgery. There can be some discomfort for a couple of weeks too as the body adjusts, but most patients can be free of medication either permanently or for many, many years. Luckily, many cases of GERD can be managed with medications and lifestyle changes, but chronic cases can sometimes lead to a variety of different complications. For those patients with persistent symptoms, such as myself, an upper endoscopy is recommended every 3 to 5 years so that the doctors can monitor potential esophageal erosion and so they can catch any problematic complications. Endoscopies are also an excellent way to confirm if H. pylori is present, and H. pylori is a pretty serious bacteria in the gut that plays a role in esophageal cancer risk. Chronic acid in the esophagus coupled with heightened life stressors can lead to the potential for very painful esophageal ulcers. These can usually be treated with a mild diet, sometimes medications, and if H. pylori bacteria is present, then antibiotics can be used as well. Some of the different complications that can result from GERD, one of them is esophagitis, which is the irritation and inflammation of the esophageal lining. This can result in chronic GERD that's not being managed well by medication. It can vary from mild to severe and cause erosion of esophageal tissue, ulcers, and even esophageal strictures. Scarily, it can lead to upper GI bleeding, which can be serious enough to cause deadly hemorrhaging in some cases. Proton pump inhibitors are usually diagnosed